Gender Identity Disorder in Remission Desistance. Our proposals will be presented by Dr. Kirk Miceli of Do No Harm. He will do the clinical presentation, after which 1 to 2 questions can be asked, and then the coding modifications will follow. Dr. Miceli?
Appreciate it. Thank you, Cheryl.
You're welcome.
And good morning. As Cheryl mentioned, my name is Kurt Miceli. I'm Medical Director for Do No Harm, and I appreciate the opportunity to present to you today on a variety of codes primarily related to desistance and detransition being requested as additions to the ICD-10-CM. Currently, there are no formal means to document these clinical realities, hindering clinical care and real-world research. Next slide, please. As it exists within the ICD-10, gender identity disorder captures what is termed gender dysphoria in the Diagnostics and Statistics Manual of Mental Health Disorders, 5th edition. It is based on 2 criteria. Criteria A describes the marked incongruence that one experiences between one's experienced expressed gender and assigned gender, or one's natal sex. It is of at least 6 months duration, and it's manifested by a series of descriptors that are provided in the DSM, a set of descriptors for children and a set for adults and adolescents. Criteria B notes that the condition is associated with clinically significant distress in some important area of function. And that can be social, academic, occupational. Next slide, please. Also within the DSM-5 is a specifier for post-transition. In this case, the individual has transitioned to full-time living in the desired gender and has undergone or is preparing to undergo at least one cross-sex medical procedure or treatment regimen. And this can include medications like cross-sex hormones or surgeries. And when we look at minors, for instance, we see a variety of surgeries, of which mastectomy is the most common, as an example. It's clear the incongruence still remains and the individual is engaging in active treatment in an attempt to align their experienced expressed gender and their natal sex. Next slide, please. What if, however, this cognitive incongruence and the associated distress resolve? Researchers have found that many kids who display this incongruence ultimately remit as they grow older. Those numbers are upwards of 80% or more for kids, particularly for those who haven't undergone medical or surgical interventions. And this reality is that for many, this marked congruence between the experienced expressed gender and the assigned gender can resolve. These individuals come to accept their natal sex, and the distress that had come from that incongruence is no more. This would be captured by a true state of remission, or what we would call desistance. Currently, this reality is not accounted for in the ICD-10. Next slide, please. As we seek to understand desistance and ultimately detransition, let's first explore gender transition itself. Gender transition can be quite heterogeneous, and we've placed it in 3 buckets here: social, medical, and surgical, to capture those different aspects of gender transition. Social transition entails those elements such as changing one's name, pronouns, or manner of dress, but also includes practices such as tucking and binding. Medical transition includes medications such as puberty blockers and cross-sex hormones used to align an individual's physical characteristics with their gender identity. And then lastly, there are surgical procedures that ultimately alter, modify, or remove physical or anatomic characteristics or features that are typical for the individual's natal sex in order to align with one's gender identity. And this involves the removal of otherwise healthy body parts. The number of procedures is more extensive than what's listed here, but includes life-altering surgeries, many of which are technically difficult and come with high complication rates. Next slide, please. Currently, the idea of transition, and really one limited aspect of it, is encompassed in the ICD-10-CM codes, and that code is personal history of sex reassignment. This code doesn't take into account the varied dimensions of gender transition that we just spoke of. Thus, it is essential to more clearly elucidate within the coding hierarchy the historical actions of transition or sex trait modification. For improved specificity, we propose that the code Personal History of Sex Reassignment become a category for 2 new codes, and I'll speak more to that later, but one for surgical procedures and one for medical interventions that are related to these sex trait modifications. Next slide, please. We also propose adding a code for social transition, and this would give us one code for each of the three different aspects of transition: social, medical, and surgical. We know that transition, or any action that's taken in life, does not come with just its intended effect. There are complications or side effects that can result, and we believe that these should be documented alongside the diagnostic codes. This will improve data collection and enhance our understanding of the impact that these treatments have had on individuals. In the case of mastectomy, for example, the risk of necrosis or scarring is real. More concerning, some genital surgeries like vulvoplasty have complications near 50%, including infection and wound healing difficulty. But complications are not exclusive to surgery. We know that chest binding can result in shortness of breath, and genital tucking could lead to testicular pain. Similarly, estrogen use in natal males can result in infertility and increases the risk of venous thromboembolism and even ischemic stroke. Likewise, puberty blockers can decrease bone mineral density and increase the risk for osteoporosis and consequently fractures. Next slide, please. Much as one may transition, one may also detransition. We spoke about this a few moments ago when discussing desistance, which again captures that cognitive acceptance of one's natal sex and remission from gender dysphoria. For those who have transitioned, whether medically or surgically, however, and they seek to reverse that process, we need to take into account their detransition. Estimates for detransition or regret, which I'll speak about a little bit later, following a medical or surgical treatment are up to 10%. And in one study, the implied rate of detransition was 30%. But I think it's important to note, and as does the HHS report on treatment for pediatric gender dysphoria, that detransition, the rate of detransition, is actually unknown. And so these numbers are a little unclear, but we know that these individuals are obviously there, and we understand the challenges that are faced, particularly without the classification. And so although the reasons for detransition may vary, one can desist and now identify with his or her natal sex. Others may fear medical complications from a transition, while for others it might be due to external pressures or the inability to pay. Next slide, please. We spoke earlier of the physiological complications of transition. We also need to take into account the psychological consequences. Regret, for example, can be profound in terms of the grief that one experiences, particularly when faced with lifelong, permanent physical changes made to one's body. Loss and mourning may very well ensue. One may no longer be able to breastfeed as a result of having had a mastectomy, or may not be able to have children because of the effects of infertility from cross-sex hormones or sex reassignment surgeries themselves. Furthermore, self-hatred and isolation after transition may result. Feelings of betrayal by clinicians and medical institutions are also apparent. The erosion of trust may extend to other relationships, and in fact, loss of those relationships and community may only further one's isolation and worsen one's distress. The psychological impact of transition is real and often heard through the stories of those who have detransitioned. They have openly and courageously shared their pain, a pain which can certainly take on clinical significance with impairment in various aspects of functioning. Next slide, please. To best account for these clinical realities described in this presentation, we propose the following codes that you see on this slide. I'll speak to these more when we go to the tabular modification, but just wanted to at least list them here for you. Next slide, please. Clearly, a significant gap exists in research as well as clinical practice given the lack of diagnostic codes for desistance and detransition and the ones that we've mentioned. With increasing rates of gender dysphoria and evolving clinical and policy decisions and an uncertain rate of desistance and detransition, it's more critical than ever to capture precisely these clinical entities. Our proposed diagnostic codes really do aim to give visibility to those facing these clinical conditions. We need to move past the erroneous narrative that those with desistance and detransition do not exist. Currently, their clinical status remains invisible to medicine's classification system. Our proposal aims to support the collection of valuable health information for research. Additionally, data based on these codes can inform public health needs, particularly given the growing rates of gender dysphoria and subsequently desistance and detransition. These codes will also provide for more accurate clinical coding and thus improve clinician-to-clinician communication through the medical record.
1 minute remaining, Dr. Miceli, sir. 1 minute remaining.
Thank you. There are no established guidelines for clinicians to follow that allow patients to be safely weaned off cross-sex hormones, for example. And so it's important for us to understand what to do in these situations, and we believe that the classification codes in this case can help to augment the research that can support that. And ultimately, our codes aim to improve patient care and quality. We need to meet people's health needs, and we need to recognize those needs of those who've detransitioned and those who have desisted. And so we hope that you accept this proposal and appreciate the time that you've allowed me to speak to it. Thank you so much.
Thank you. Do we have any clinical questions or any hands raised at this time?
Raised hands.
Thank you. You can continue with the proposed tab of the modifications.
Excellent. Would you have those two placed on the screen?
Yes, we will.
Oh, wonderful. Thank you so much, Cheryl.
Certainly.
One moment as they're coming up shortly, Dr. Miceli.
No, I appreciate it. Thank you so much.
Okay, Dr. Miceli.
Perfect. Yeah, maybe.
Are you
There we
able?
are. Excellent. Excellent. Thank you. So currently, the tabular modification has F64 for the category of gender identity disorders. What we are proposing is to add a code for gender identity disorder in remission desistance, which would be F64.A. That would account for the desistance that folks gone through who no longer have that marked incongruence between their experienced expressed gender and their natal sex. We also understand that the distress that we spoke of, the regret, the self-hatred and such, will be captured by a code post-transition distress, F64.B, which we are recommending. In speaking to the personal history of sex reassignment, we are proposing that that be a category and thereby allow two different codes to remain under it, which would be personal history of sex reassignment as related to surgical as well as medical. But I think it's also important to note that we are looking to recommend that optional coding be added for complications that can result from the personal history of sex reassignment. And that's whether or not someone has, no matter what the outcome might be, but recognizing that there are complications and side effects from these procedures. And so we propose the Z87.8901 personal history of sex reassignment surgical, again, to which one could code any resulting complications should they exist. And then I believe on the next page, we'll see the Z87.8902, which would account for the medical medications, cross-sex hormones and such that one may have utilized in their sex reassignment. We recognize the importance of social transition and for documenting that, particularly given the medical complications that can result. And so we offer Z87.893 to account for those. And lastly, we also look to the personal history of detransition to really, again, give visibility to those who have undertaken detransition and to understand their specific medical needs. And that is embodied by the Z87.894. And again, for all of these various codes in the Z section, we highly recommend and encourage the addition of optional codes that could account for any complications that may have resulted to really give us better data to support the research and to allow us to really understand how we can better treat and support those who have undergone a detransition or who have potentially complications from transition itself. And I believe those are the 6 codes that we are proposing.
At this time, moderator, do we have any questions? Thank you, Dr. Miceli, for going through the tabular modification.
I think there are no raised hands. We have Linda. Your line is unmuted. No more raised hands.
Okay.
Sorry.
And okay, Linda.
Yes.
Linda, yes, go ahead, Linda.
Thank you. I'm Linda Holtzman from Clarity Coding. I have a couple coding questions. I don't know if I should direct them to Dr. Miceli or to CDC, but is there a default on personal history of sex reassignment, surgical versus medical? is there a default if you don't know? In other words, if I just see in a record that, someone is, has a history of sex reassignment, I don't know, they don't mention it, which it is. So do we default to medical or surgical, or do we need another code for, unspecified? That's one question. Also, if someone has a surgical reassignment, my understanding is they will continue to take medication for the rest of their lives. So, should we use both? If that's the case.
Yeah, Linda, those are really great questions, and I appreciate you asking. I mean, certainly from the clinical perspective, there may be folks who have undertaken surgery, depending on what that surgery is, who may necessitate cross-sex hormones in order to have those hormones. There might be others, depending on what the surgery is, who may not need them. But I think, for the vast majority who are in a state of transition, typically folks have gone from medications to surgeries and are continuing to take surgeries at the same time. And so for those folks who have both had the surgeries and have had the medications, I mean, I would think to use both codes for that situation in which they have a personal history of both having had a surgery and both using medications.
Thank you. Thank you, Dr. Miceli. And Linda, thank you for your questions from the coding aspect. We will definitely take those back internally here at CDC.
Thank you. Can I ask another question real quick?
That will be our final question time allotted. But yes, Linda, go ahead.
Okay. I don't want to take up time if someone else has a question, but can you tell me again about personal history of gender transition social? I might have missed it, but I'm not sure if I understand what.
No, absolutely. No, thank you for that. So oftentimes individuals will socially transition in the sense of taking the name of the desired gender or using pronouns and such. But I think more from this aspect related to the medical aspects, it might be the tucking or the binding or what one might do. So a girl, for instance, who sees herself as a boy may very well engage in binding of the breast so that she has a flat chest. That could potentially result in shortness of breath and other, potential complications from having done that. So that's why we believe it would be helpful to have that code in. Again, certainly due to whatever the complications may arise. And I think it also gives some more clinical clarity to the essence of the state at which one is in terms of their transition.
Okay, thanks.
No, thank you. No, thank you. Thank you so much. Thank you, Dr. Miceli. Thank you, Linda. At that time, we will be transitioning on to our next topic.